We are continuing with the arterial supply of thyroid gland. So you already know the thyroid gland has got two lateral lobes and an isthmus. So can you name the main arteries supplying the thyroid gland? One is the superior thyroid artery that is related to the upper pole, and related to the lower pole you have got the inferior thyroid artery. So these are the two main arteries. One is the superior thyroid artery, the other one is the inferior. So what is you see here? This is the superior thyroid artery, inferior thyroid artery. Fine. So this superior thyroid artery is a branch coming from the external carotid artery. Fine. So you find the external carotid there, and the external carotid gives a superior thyroid artery which comes and it is very closely related to the upper pole, then divides into an anterior branch and a posterior branch. This anterior branch will descend along the anterior border, and you find will be anastomosing with the branch coming from the other side superior thyroid artery, and the posterior branch will be going along the posterior border where it will be anastomosing with the inferior thyroid artery that is coming from the lower end. Fine. So this upper pole, I've already mentioned, the upper pole is very closely related to one nerve also. Do you remember that nerve? That was the external laryngeal nerve. So this external laryngeal nerve was going to supply which muscle? Cricothyroid muscle. So what happens is the superior thyroid is very closely related to the upper pole, and you find the nerve is also coming very close to the upper pole, but once it reaches the upper pole, before reaching that nerve will go further deep so as to supply the cricothyroid muscle. So once you ligate the superior thyroid artery very close to the upper pole, then it is very safe. Why it is so safe to ligate the superior thyroid artery close to the upper pole? That is because the external laryngeal nerve, once it reaches very close to the upper, it will not come towards the upper part, it will be passing certainly deep so as to supply the external laryngeal nerve will be passing deep so as to supply the cricothyroid muscle. So that relation should be there in your mind when you are doing a thyroidectomy. Fine. And similarly, the lower pole, I already told you the lower pole, you find one artery. Which artery? That is the inferior thyroid artery. And this inferior thyroid artery is a branch coming from which main artery? Do you know? It is a branch coming from thyrocervical trunk of subclavian artery. Okay, so superior thyroid artery was coming from your external carotid artery, and inferior thyroid artery was coming as a branch of thyrocervical trunk of subclavian artery. And I already told you this inferior pole is also related to one nerve. Which nerve was it? It is the recurrent laryngeal nerve. So what happens at the lower pole of the thyroid gland? You find this inferior thyroid artery will be very closely related to the recurrent laryngeal nerve, and if you ligate this inferior thyroid artery very close to the lower pole, there is severe chance, or there is more chance to injure the recurrent laryngeal nerve. So you always ligate the inferior thyroid artery away from the lower pole. That relation you should remember. Upper pole, you ligate the superior thyroid artery very close to the lobe, but the lower part, you ligate the inferior thyroid artery away from the lower pole so as to prevent injury to the recurrent laryngeal nerve. Fine. So one more thing you have to remember, I mentioned the main arterial supply is by superior thyroid artery coming from the external carotid artery, plus the inferior thyroid artery, which is a branch of thyrocervical trunk, and you know the relations and where to ligate these arteries in the upper pole and the lower pole because of its intimate relation to two nerves related there, external laryngeal nerve and recurrent laryngeal nerve. I think you understood that. One more thing you should remember there is, in addition to these arteries, in certain individuals, you find an additional supply there, and that is what is termed as thyroidea ima. Thyroidea ima. In certain percentage of individuals, you find this artery coming as a branch of either brachiocephalic or arch of aorta, not present in all. In certain individuals, you will be able to see this third artery also. They are termed as the thyroidea ima. Fine. So with that, we finish the arterial supply. So now, next part, venous drainage. So when you were learning about the capsule, do you remember there were two capsules, one a true capsule, the other one false capsule, and I said the true capsule was a condensation of connective tissue. Outer to that you find the false capsule that is produced as a modification of pretracheal fascia. Do you remember that? And there I mentioned about a plexus, venous plexus. Do you remember that? Where did I mention the presence of the venous plexus? I mentioned it that venous plexus will be lying just deep to the true capsule. That relation was really important. Remember that the venous plexus will be lying deep to the true capsule, and from this venous plexus you have the veins arising, and three sets of veins you describe for thyroid. The superior thyroid vein, then you have got the inferior thyroid vein and the middle thyroid vein. So these three, first the superior, the middle and the inferior thyroid vein. So always remember, these thyroid veins are not like that of your arteries. It does not follow the same pattern as that of arteries. So this superior thyroid vein and middle thyroid vein will be draining into the internal jugular vein. You are seeing the internal jugular vein, and you find this internal jugular vein on both sides you are seeing. Are you appreciating in that figure? You are seeing in that figure, this is the internal jugular vein on either side. This is the superior thyroid vein. This is the middle thyroid vein. On both sides you see they are draining into internal jugular vein, and this inferior thyroid vein you find it is draining into the brachiocephalic vein. Fine? And one more thing you should remember is, in addition to these three sets, you find one more vein termed as the Coccus vein. So Coccus vein will be present in between, midway between the middle and inferior, and that will drain into the internal jugular vein. So just read that description. You find just beneath the true capsule, you find the deep venous plexus draining into veins. Three sets of veins usually, the superior thyroid vein, the middle thyroid vein and inferior thyroid vein. Superior and middle thyroid veins will drain into the internal jugular vein, and inferior thyroid vein will drain into the brachiocephalic vein. Fine. And in addition to that, you find one more vein termed as the Coccus vein. So this Coccus vein will be present between the middle and inferior thyroid vein, and that will also drain to the internal jugular vein. So all the three, superior, middle, Coccus, will drain into inferior jugular vein, and you find the inferior jugular vein is draining into the brachiocephalic vein. So with that we finish the venous drainage. Now comes the lymphatic drainage. The upper part of the thyroid gland is mainly drained into the upper deep cervical nodes. To be more precise, they go more to the jugulodigastric nodes. Fine. And the lower part you drain it into the lower deep cervical nodes, that is the jugulo-omohyoid nodes. So why this lymphatic drainage becomes important is, you should be familiar with a condition termed as the papillary carcinoma of thyroid gland. That is one carcinomatous condition affecting the thyroid gland, where in the initial stages nothing, no pathology or nothing abnormal, no swelling, nothing will be observed in the thyroid gland, but the only presentation at that stage will be an enlarged lymph node. That is because of this rapid lymphatic spread in the case of papillary carcinoma of thyroid gland. That thing you should remember. So the normal lymphatic drainage, upper part mainly goes to the upper deep cervical, that is the jugulodigastric, the lower part into the jugulo-omohyoid nodes. So with that, we finish the lymphatic drainage. Now we come to the last part, development. So this development of thyroid gland is really important. Where does this thyroid gland develops from? It is actually endodermal in origin. That is, from the floor of the pharynx, you have got a diverticulum coming. Look at that, from the floor of the mouth, floor of the from the endoderm, or from the floor of the primitive pharynx, you find a small diverticulum running downwards, and that is what is termed as, or a, not a diverticulum, a small duct extending downwards, and that is what is termed as the thyroglossal duct. So in that figure, you are seeing the thyroglossal duct. So the precise point from which this duct extends downwards, that precise point is becoming the foramen cecum. Foramen cecum. So the thyroglossal duct will be extending down from the floor of the pharynx, that is the endodermal origin. It descends down in front of the hyoid bone, thyroid cartilage. Then what happens is it divides into two, forming the two lobes. And then what happens, the upper part, the cranial part of whole of the thyroglossal duct will degenerate. If certain part very close to your thyroid gland persist, that will persist as a glandular tissue there, termed as the pyramidal lobe. So look at that. Actually, the thyroid gland is developing from the endoderm of the floor of the pharynx at foramen cecum. That is the point, foramen cecum, from which you got the downward extension of the thyroglossal duct. And what happens is, this thyroglossal duct will pass in front of the hyoid bone, thyroid cartilage, cricoid cartilage, and then divides into two, becomes bilobe so as to form the gland. Always remember, not whole of the thyroid gland is produced from the thyroglossal duct. No. Some contributions of the thyroid gland is actually received from the ultimobranchial body also. So when you're thinking about the development, don't think everything, whole cells are developed from the thyroglossal duct. No, it's not like that. The majority is derived from the thyroglossal duct, but some contributions, to be more precise, the parafollicular cells. The parafollicular cells are actually derived from the ultimobranchial body, that is coming from the pharyngeal complex. So this ultimobranchial body contributes in the formation of the parafollicular cells. The rest, all other parts, is derived from your thyroglossal duct. And what happens, the cranial part of the thyroglossal duct will degenerate, and that part, that bilobed part, will form your two lateral lobes plus isthmus. If certain parts, very caudal part of the duct persist, it can become the pyramidal lobe. So I think now the development of thyroid gland is clear to you. So once the normal development is clear, you should be very well aware of some anomalies of the development also. So one, you already know, the caudal end persists as the pyramidal lobe. Okay, the caudal end is persisting as the pyramidal lobe, and there could be situations where the thyroglossal duct failed to descend. I told you it is actually starting from foramen cecum and is coming down in front of hyoid and thyroid cartilage. But in certain cases, this duct will fail to descend. Then it will lead to lingual thyroid. Okay, lingual thyroid. Plus, you find the ectopic thyroid also. The thyroid tissue can be classified as suprahyoid and infrahyoid, and that you call it as the ectopic thyroid. Now what happens is, this whole of the thyroglossal duct will be there. In certain regions it degenerates, but in certain regions it will persist, and this duct will present as a cystic swellings in certain regions of its development. So that is what is termed as thyroglossal cyst, a cystic swelling present along the pathway. And later what happens, that cyst could become infected and then lead to a fistula. That is what is termed as thyroglossal fistula. So these are some of the developmental anomalies that should come to your mind once you think of thyroid gland. One, it could be a lingual thyroid, ectopic thyroid, then thyroglossal cyst, thyroglossal fistula, plus the pyramidal loop. So this much details of the development I think you can remember. Okay. So these are the different things. You are seeing the foramen cecum marked there, and then you are seeing the normal position, normal route of descent of the thyroid gland, thyroglossal cyst duct, then ectopic thyroid, you can see there. Then you can see the different positions of thyroglossal cyst, like that. So with that we finish the normal development. Now we are going to the last part, applied anatomy. So first one, a very familiar condition, goitre. Enlargement of the thyroid gland is what is termed as goitre. Could be a physiological in certain cases of pregnancy you find a small goitric enlargement will be there. And in certain cases this enlargement, iodine deficiency you find goitre is there. And different varieties of enlargement of thyroid gland you see. In certain cases, this whole of the enlargement of thyroid gland will be so much or so large that it will press the surrounding structures, or it will compress the surrounding structures and produce the effect depending upon the compression. One is if it presses on trachea, immediate posterior relation trachea, it can lead to dyspnea. Esophagus, it can lead to dysphagia. Recurrent laryngeal nerve, very closely related. You find recurrent laryngeal nerve is related just very close to the inferior lobe. Then you find this recurrent laryngeal nerve is then passing upwards along the tracheo-esophageal groove and then going to supply the muscles. So what happens anywhere if this recurrent laryngeal nerve is compressed, that could lead to hoarseness of voice. And then you remember the posterolateral surface, just very close to that you find the sympathetic chain also. If that gets compressed, that could lead to Horner syndrome. So depending upon the compression, this is not in the case of very small swelling, a very huge swelling compresses the surrounding structures leading to different manifestations. Fine. And toxic goiter. So what is this toxic goiter? If this goiter, if the swelling is associated with conditions of hyperthyroidism, then you call it as toxic goiter. And one typical presentation you get there is exophthalmos, that is the bulging eyes. In that figure you are seeing the bulging eyes. Plus other manifestations will be there, palpitation, tremor, anxiety, like that. See, these are all features of toxic goiter. Now, care during ligation, extreme care during thyroidectomy. I have already mentioned why ligating the upper pole and the lower pole. Do you know? Or you know where to ligate the upper pole superior thyroid artery so as to prevent injury to your external laryngeal nerve, lower part to prevent injury to recurrent laryngeal nerve. So that care during ligation should be there. Plus the developmental anomaly that we have already discussed, that is the thyroglossal cyst. And what is this nuclear scan? So nuclear scan we do to look the functional status of the thyroid gland. So what we do is we take radioactive iodine. Radioactive iodine is given orally and the photographs are taken. And what happens is if certain parts of the thyroid gland is hyperactive, that will appear as hot spots. And in certain regions, if it is hypoactive, that will appear as cold spots. Fine. So that is the next applied aspect that you should remember, nuclear scan. And next is thyroidectomy. Thyroidectomy, different types of thyroidectomy are there. One is lobectomy. The figure you are seeing, only one lobe is removed. That is what is termed as lobectomy. Then you get subtotal thyroidectomy. Then you get total thyroidectomy, when whole of the gland is removed, total thyroidectomy. So different types of presentations, lobectomy, subtotal thyroidectomy and total thyroidectomy are there. Fine. So that is a lobectomy being shown to you. So I mentioned the different types, but there are a large number of complications can arise during a thyroid surgery. And one of the very common or very dreaded complication is injury to recurrent laryngeal nerve. I told you the lower pole is related to inferior thyroid artery and recurrent laryngeal nerve. And so while tying this or ligating this inferior thyroid artery, extreme care should be taken to identify this recurrent laryngeal nerve. Fine? And what the surgeons do is they take ultimate care, they dissect the lower pole, they identify the recurrent laryngeal nerve, separate it, and then you ligate the artery. In addition to that, suppose there is a removal of the parathyroid also along with the thyroid gland, that will lead to parathyroid insufficiency, otherwise termed as tetany. Okay, so these are some of the complications. Hemorrhage will be there, other complications also there. See, these are some of the complications that you should remember of thyroidectomy. I think with that we finished the thyroid gland. So what all things we discuss, you know the position, some details about the capsule, plus the applied aspect, remembering that, plus the relations of lateral lobes and isthmus. Lateral lobes, each lobe had three surfaces: superficial, medial, posterolateral, two borders, anterior and posterior border. Then the relations of isthmus, arterial supply we mentioned, the venous drainage, the lymphatic drainage, then the development of thyroid gland, and finally the applied aspects. So with that we finish the topic, and I think the whole topic is now clear to you. Okay, so can I stop?